Stephen Feathers. I'm from Perception Programs, the Risk Reduction Department. We do HIV and hepatitis C testing and education, naloxone training, and syringe service program. So if people have questions about that, I'm the person to ask. We're going to go over naloxone training tonight. Next slide. The first big thing is that my entire department is based around harm reduction. So harm reduction is simply a tactic to reduce the negative consequences from actions people are already going to be taking anyway. We're not judging them for what they may or may not be doing, and we're not assuming that they intend to harm either themselves or others. You can see on the bottom, like we wear masks, we put on sunscreen, we wear seat belts, we wash our hands. The idea of all these things is that we're just trying to do simple actions that can reduce the possible risks to things we're already doing. That's all harm reduction is. So next slide. We're just going to be covering naloxone, which is an emergency medication to reverse opiate overdose. It's oftentimes known as Narcan because that's the name brand for one of the most common intranasal versions of it. Next slide. So the way Narcan works is it is more strongly attracted to the opiate receptors in the brain. So it forces the opiates out of the brain. What this means is that those receptors can start working again and start telling your body how to breathe. Because when an opiate overdose happens, the opiates clog up those receptors so they can't work. And they both control our sensation of pain, but also our breathing. So when they get clogged up, we're not able to breathe, and we also go unconscious. So those two things together is what leads to the overdose and the eventual death. The Narcan forces the opiates out of the brain. It does not remove them from the person's system. It just kicks them out of the brain. So what that does mean is that the person still needs time for their body to filter the opiates out of the system so they can go back into an overdose, because most opiates last significantly longer than Narcan in somebody's system. So there is a chance that somebody can go back into an overdose, even if they haven't taken any additional opiates. It just depends on what they took, when they took it, and how their body's reacting. The other part of this is that especially if somebody is coming from a history of opiate use, so their opiate use disorder, they can go into what's called precipitated withdrawal. So essentially what that means is that they're experiencing opiate withdrawal because of the naloxone kicking all of the opiates out of the brain. When we have people come back to the syringe service program, 9 times out of 10, when they tell us about either reversing their friends or their friends reversing them, the person who is getting Narcan is out of it, not sure what's going on, and puking their guts up. They're generally not aggressive, but we do sometimes hear that when a layperson is doing the response, it is an aggressive response. Once again, that's rare, but if that's the case, our recommendation is just try and keep them calm, let them know that you reverse the overdose with Narcan, helps on the way, they're not getting in trouble. If they decide to book it off down the street, that's on them. You've done what you can to keep them safe. I'm sure if you ask our doctor from Bacchus Hospital, they have a higher instance of people being a little bit more aggressive. It seems to be that for the most part, when somebody is reversed by lay people, they're more likely to be calm as opposed to aggressive, and you kind of reverse the odds.
Stephen, I'm sorry to interrupt you.
Yep.
I had a pause at the word odd. Did you get cut off, or was that just on my end?
I don't know that I got cut off.
Okay.
I was able to hear him all the way through.
All right,
Yeah, we
great.
can
Thank you.
hear.
All right, thanks.
Okay, good to know. All right, so if you just want to bring this up, an opiate overdose, as I was saying, it stops the body from being able to breathe, and it also leads to unconsciousness. 3 to 5 minutes after somebody stops breathing is when brain damage and nerve damage start to set in, which can eventually lead to coma and death. So the quicker you can get that person assistance, the better their chances are for a more full and complete recovery. On to the next slide. There are some factors that make it easier for somebody to have an overdose or make it more likely. The The biggest one is tolerance shift. That's just if they have any period of sobriety for any reason whatsoever, any length of sobriety. That's going to increase the risk of overdose when and if they relapse, or when and if they're re-exposed to opiates. The variation in strength and content is just there's a lot of different strengths of opiates. And if somebody gets something that's 50 to 100 times stronger than what they're expecting, that's going to be a very different experience. Mixing drugs is every time we get a prescription from our doctor, we go to the pharmacy and the pharmacist looks at the list and tries to make sure there's no drug-drug interactions. When somebody's getting stuff on the street, nobody's doing that for them. So anytime somebody's taking additional substances, there's increased risk. And then also, anytime somebody switches how they use a substance, it changes how much of it gets absorbed by their body and how quickly it's absorbed. So that can dramatically change the experience. Physical health is just everyone's different. And then using alone is more risk factor for them actually having death as a side effect or an end result, because nobody's able to get them assistance. On to the next slide. So there's 3 universal signs of an overdose. These are the ones that are going to happen for everyone who's experiencing an opiate overdose. It's going to be pinpoint pupils. They're going to be non-responsive to stimulation, and they're going to have slow or no breathing. Press one more time. Depending on when they stopped breathing and when they went into an overdose and how their body's processing everything, they may also get blue lips or fingertips, pale, clammy skin. They may have an abnormal snore. It's sometimes called a death rattle. Kind of think a real like sleep apnea on steroids. They may have slowed or no pulse. They may seize or they may vomit. The easiest one for you to check is non-responsive, because that's going to happen for everyone. And it's going to be the easiest of the 3 things. All right, on to the next slide. Right?
Are we good?
Yep, we're on to the next one. So when you're trying to respond to an overdose, if you see somebody who you think is experiencing an overdose, the first thing you want to do, the same as any first aid CPR scenario, is check the scene, make sure it's safe for you. You don't want to put yourself in danger. If it's safe for you, check the person. If you know their name, give them a shout, give them a shake on their shoulder. If they don't respond, you can do one of 3 things. So the first one is pinching the outer part of the arm. One of my coworkers used to call it sibling wrestling 101. You're trying to cause pain, but you're not trying to cause damage. So you essentially grab the outer part of the arm and just squeeze as hard as you can. You can also take knuckles and do a chest bone rub. So that's the center of the chest, just rub up and down on that bone. You can also take a knuckle and grind it in the divot between the nose and the lips. All 3 of these things hurt if you do them to yourself, but the idea is that they're not causing damage to that person. If they respond, you do not have to call 911 because they are responsive. You may still wish to, because you may not be comfortable monitoring their symptoms, and you may not be aware if there's anything else going on that needs to be addressed medically. But if they're responsive, you don't have to call 911 at that point. On to the next slide. I can't remember which one's next. So if you have to leave them for any reason, the same as any other first aid CPR scenario, they're unconscious, you want to put them in the recovery position. So that's one arm up, one arm across, pull the leg across. On to the next slide. The idea is you want them lying on their side. So if they do throw up, it's not going to block their airway. On to the next slide. So you've assessed the scene, it's safe for you. You've checked that person. They didn't respond when you gave them a shake on the shoulder. They didn't respond to one of the physical stimuli. At that point, you've called 911. So if we click once more, the next thing you're going to do is you're going to administer a dose of naloxone. I recommend waiting about 5 seconds, because sometimes it works almost instantaneously. If it does not work, at that point, what you're going to do is you're going to do CPR as you are trained, certified, and comfortable doing, or as directed by the dispatcher for 2 to 3 minutes. The idea is you're trying to get blood flowing and keep oxygen in the blood, and that both brings oxygen and the naloxone to the brain. So there's a chance for that medication to start working. If the person hasn't woken up after the first 2 to 3 minutes of CPR, you can give the second dose of naloxone because each prescription comes with 2 separate doses. You would then continue CPR until either the patient revives, trained assistance arrives to take over, or you cannot continue without injuring yourself. So if we go to the next slide, there's 2 versions of nasal Narcan that are primarily what you're going to be seeing. For the most part, what you're familiar with is the Narcan nasal spray on the left. It's going to come in a box. Let me see if I can center it in my camera. That looks something like this. This is going to be what most people are familiar with. There is now a generic version that just got released of that. So it's the same exact 4 milligram dose. It's the same exact administration. There's also now Kloxxado, which just got released earlier this last year. That is made in the same manufacturing plant with the same distribution. It's also a naloxone spray, so it's used in the exact same manner. The only difference is the Kloxxado has 8 milligrams as opposed to 4 milligrams, but the actual administration is exactly the same as the Narcan nasal spray. When you pull it out of the package, the current Narcan nasal sprays actually have a red plunger as opposed to the white plunger. It's just to make it easier for you to find that part of the actual administration. So to use it, you put 1 finger on either side of the nasal injector, and then you put it in their nose. So their nose is right here. And then you're going to press firmly, and all the medication comes out at once as a fine mist. So finger on either side, stick it up their nose, press firmly. I recommend not putting your finger on the trigger until you're in the person's nose. I have had people accidentally discharge it on the way to the person's nose before it got there. Once again, any version of Narcan or naloxone that looks vaguely like this is going to be used in the exact same manner. Finger on either side, stick it up their nose, squirt. The main suspected difference between the Narcan 4 milligram and the Kloxxado 8 milligram is that there's suspicions in the harm reduction community that Kloxxado may have a higher rate of people being in severe opiate withdrawal, but there's not data from the company to support one way or the other on that. So that's just, it's not been out on the market for long enough for us to really know what the actual difference is in terms of use in the field. But for right now, the Narcan nasal spray is probably what you're going to see. On to the next slide. There's a couple legal things around Narcan. I know Mike mentioned the Good Samaritan law. The first thing is it protects the person who overdosed from any drugs or paraphernalia on the scene. As long as you are acting in good faith, it also protects you from any drugs or paraphernalia on the scene. In order to be considered acting in good faith, you do need to call 911. If you don't call 911, you can't really be considered acting in good faith if you're trying to save somebody from an overdose. The other part of this is that it does not protect against previous arrest warrants or the police coming back later with a search warrant. We do know that it works. We have had somebody overdose in a parking lot with all their stuff laid out on the dashboard of the car. Their friend called 911. The cops showed up. All the stuff on the dashboard got confiscated, but they both walked away without charges. So we do know that it works. On to the next slide. As Mike also mentioned, you can get naloxone from your local pharmacy. Not all pharmacies are able to prescribe it, and not all pharmacists are able to prescribe it. They do have to take an additional training in order to do it. If this is the way that you want to go about getting naloxone for yourself, your family, or a friend, I recommend that you call your pharmacy of choice ahead of time just to see if they can prescribe it and have it in stock. If so, they do a short training to make sure you know what you're doing, and then it's whatever the cost of your insurance copay for the medication is, the cost to you. So most people with insurance copays for medications, it's that $5 to $20 depending on your insurance plan. If you have anyone who's patient, client, neighbor, anyone who needs it, who's on the Husky insurance plan, it's the same $0 copay as all their other medications. CVS and Walgreens essentially did a corporate edict saying that all of their pharmacies have to be able to do this, but not all pharmacies are able to do it at all times. I know the pharmacy I go to personally to get it, only one of their pharmacists is trained, so I have to go the day that he's actually there. On to the next slide. There's also, the state has the NORA naloxone overdose response app. It's a website that you can just go to. It gives you a quick overview of signs of an overdose, how to respond, and how to use all the different versions of Narcan that are out there, because there are multiple different versions, both intramuscular and intranasal. As I said, primarily you're going to find that intranasal version that's in the prepackaged blister pack with everything ready to use. But depending on where you are or who you're with, they may have an older version of Narcan or a different version of Narcan. So you can familiarize yourself with how to use it through that website. On to the next slide. So big things to remember: call 911. The Good Samaritan law protects both the person who overdosed and you from any drugs or paraphernalia that are on the scene. The idea is we want that person to get revived so they have another chance to make whatever decision they're going to make at that point in time. And hopefully they're at the hospital and are getting some of the resources that Dr. McNeil, I think I'm remembering that correctly.
McLean, it's fine.
McLean, sorry, mentioned as available to help people get a little bit closer to whatever their end goal is. Narcan is temperature sensitive. If you're comfortable, it's probably fine. Don't leave it in the glove box of a car. And then the biggest thing is you don't know how you're going to react in an emergency situation. The 911 dispatcher's job is to help you walk through what the best way to help that person to the best of your ability is at that moment. That's what their job is. So if you forget everything, calling 911 is both going to get help on the way and also give the 911 dispatcher a chance to coach you through what you might still be able to do to help that person out. On to the next slide. Similar to Mike, I will post my information in the chat. This is my work cell phone. You can call or text it. I do have some naloxone kits available specifically for people who are either actively using or are close friends or family of someone who's actively using. There's also a number of community programs in the Norwich area that do periodic Narcan trainings where they give out Narcan kits as part of the training. And those trainings are a little bit more in depth and a little bit less rushed than this one. We also do HIV and hepatitis C testing, and we also run the syringe service program. So if somebody's actively using, we can give them some resources to be a little bit safer until they're ready to make that decision about what other changes they might want to make. So if anyone has any questions about those, please feel free to reach out. Once again, I'll put my information in the chat.